I'll just shift gears to try and come to the biggest bugbear for all of us, not only as cataract surgeons, but even in our general clinic. Nobody likes to wear once they cross 40, and when they suddenly have to start wearing glasses for their constant WhatsApp and SMSs, that's what bothers them. So I think presbyopia treating is probably the biggest or the next frontier or the next hurdle that all of us as cataract surgeons need to face, and I would like to acknowledge that we do as an institute receive research grant support from Alcon Laboratories. So I think there are various strategies for correcting presbyopia. The oldest and still very popular among most surgeons is monovision strategies, where one eye is corrected for distance and the other eye is left myopic for distance. The traditional or the formulas or the intraocular lenses with higher plus diopter ads, like +3, +3.5, +4 diopter ads, the traditional multifocal IOLs, or the low ad multifocal IOLs with say 2.5 to 1.5 diopter ads, the extended depth of field of IOLs, the trifocal IOLs, and now there are small aperture IOLs as well coming up in the market. So there are so many options that all of us have, but still we are still struggling to find the best solution for each patient. And these are some of just the representatives, and there are plenty of companies making equally good lenses amongst all of them. So the advantage of a traditional multifocal IOL is that it has two foci. So basically it's a bifocal IOL where it has two foci, one for distance and one for reading. And with having understood the patient, and if they are okay with certain optical phenomenon that are likely to occur post-operatively, I think this worked very well in all of those patients, particularly early on when the multifocals came. So they sort of take care of most activities. There is a drop in the contrast at all distances, and most of them do require extra light for reading. And there is also the phenomenon of light-related dysphotopsias of glare, halos, and so on. So it's a trade-off between flexibility of vision without glasses versus quality of vision. But I think with changing times and with changing lifestyles, and particularly in Asia, as all of us are seeing in our subcontinent, we are getting more and more patients in their very active professional life getting cataracts. And with extensive use of computers in all professions, and it's not just restricted to IT professionals, now including all of us are so involved on computers or mobiles, that the need for correcting the intermediate distance came up. So the intermediate distance is about an arm's length where most people would keep their desktop or their laptop at office, and that's something that most people would be ready to stretch even to see their mobile phones. So there are various ways to address these intermediate vision issues: the low power ad IOLs, the small aperture IOLs, or the extended depth of focus IOLs like the SYMFONY. And the low power ad IOLs are typically, they also give two foci. One is for distance and for near, but here the near vision is stretched forward. So if your near vision in a traditional multifocal IOL is somewhere between 30-35 centimeters, here the near point is stretched somewhere beyond 45 to 50 centimeters and beyond. So you get a good distance as well as an intermediate vision. However, these patients, of course, do require, reading glasses. So intermediate distance then came that, if somebody is not having to use computers, does that make intermediate distance less important for them? I think no. In fact, intermediate distance is important for everyone, even for a retired person who is religious, who is doing pujas all day. If you are cooking, you need to see at different distances, you need to look at the gas, what's there in the bottle and things like that. So intermediate distance is not just for computer users, and I think we must look to correct it as much as possible or as far as possible in all cases. So the pros of a low powered IOL are they give a good distance vision, better intermediate vision, and there are very less chances of optical phenomenon or dysphotopsia that occur with these IOLs. Of course, they will need reading glasses, and because it's a multifocal, it will also require extra light for reading. So you need to forewarn these patients that although this is so-called multifocal, you will need reading glasses, and that's not something that is an abnormal outcome post surgery. And of course, there is the concept of the extended depth of focus IOLs or the SYMFONY IOLs, where playing with the design and the chromatic aberrations of the IOL, It's tried to try and stretch the focus to compare to give a seamless range of vision from distance until near. Again, the drawback or the flip side of SYMFONY and other similar lenses are that quite often patients do require glasses for reading, and they also tend to have optical phenomena or glare and halos relatively slightly higher than, say, low-powered multifocal IOLs. So I think most of us now are faced with this scenario of people living in urban areas and handheld gadgets. And therefore, to try and solve all of these problems came the trifocal IOL. So you were struggling with distance and near, then distance and intermediate, and then trifocal IOLs try and give us everything at the same time. That is, they have 3 different foci. So they are actually the true multifocals, that they have a good distance, intermediate, as well as the near foci. And with the early trifocals that were available for so many years, the Zeiss and the Physiol, which are doing an excellent job and doing still very well, the intermediate distance in these lenses is at around 80 centimeters. So now typically 80 centimeters is a little bit even beyond your hand range, and therefore the intermediate vision comes to be a little bit of a sort of iffy situation in some of these trifocal IOLs. And most patients, like I said, require different ranges of distance. No matter who you are and whatever you are doing, you need to see at different distances at all the time. And most often what has been noted in literature is a range of vision from 30 to about 60-70 centimeters is where most of the near and intermediate work occurs. So probably 80 centimeters may be a little bit stretched forward for many of these patients. Of course, as far as trifocal IOLs go, if you are not comfortable with the, adding one more focus into the IOL, there is of course the concept of blending different kinds of IOLs. Initially, it was blending the refractive and the diffractive type of IOLs. Now, of course, most of the refractive IOLs are out. And we have different diffractive IOLs, and the same company comes up with different diffractive IOLs of different add powers. So our experience has been with the restore, so you can sort of combine a +3 restore in one eye, that is a good distance and near in one eye, and a +2.5 in the other eye with a good distance and intermediate, so that binocularly most distances should get covered in most of these patients. However, you must forewarn them that they must not compare both their eyes because they will always prefer the lower power add for the distance and the higher power add, that is the +3 for the near. So if they compare, they'll always find one better than the other in some activities, but binocularly they are reasonably getting off with most of their activities. And therefore, to try and avoid this binocular asymmetry, we need actually a trifocal IOL which sort of covers up the practical useful range of vision from 30 to 60, 70 centimeters. Therefore, we've had experience of using the PanOptics, which on paper is a quadrifocal IOL, but basically what it tries and does is it optically tries to split the light into 4 different zones and eliminates one. So therefore, it has 3 distinct foci. That is, one is infinity, that is far. The near is about 40 centimeters. Keep in mind, this is slightly further away than the traditional +3 or +3.5 restore or Technis or Zeiss 80 Lisa. And the intermediate distance has come down to about, say, 60 centimeters. So what you get is a good range of vision from about 40 to 60 centimeters, which would take care of most of the activities. However, if people are used to reading very close preoperatively, you need to forewarn them that their near distance is going to recede a little bit by a few centimeters, and they'll need to hold their hand a little bit further away. Our experience, although has been limited, but we've been quite happy using this kind of IOL. And the strengths, this would not just relate only to PanOptics, but all other trifocal IOLs, that they have greater spectacle independence compared to traditional multifocal IOLs. But of course, they do come up with the same trade-offs as the traditional multifocal IOLs of low contrast sensitivity in dim lights and halos around light. So you need to counsel them as much as you would want to counsel a traditional multifocal IOLs. The other concept of improving near vision are the small aperture devices, that is using the concept of a pinhole. So like when we do a vision test with a pinhole, no matter however much the refractive error the patient has, if it passes through a pinhole, they see very well. So that concept is being is utilized to try and create an extended depth of field of vision, so that patients have good range of vision from distance up to near. And AIOC is the pioneer company for that. Now there are more than 2 or 3 models coming up of different central diameters to try and improve the range of vision. But the drawback, of course, is that they, of course, do require extra light, and for very fine print near work or very close near work, they would require glasses. So having had so many options now, there are so many options that it's almost confusing at times what to choose for what patient. I think we have a good choice, or it's a happy situation that we can customize the situation for each patient. And if we actually spend few minutes with the patient understanding what they want out of their cataract surgery, meaning what is their wish to do things without glasses post-operatively, I think we can customize for each eye. In a couple of cases, an 82-year-old lady, very active, very fit, still does lot of reading, does lot of Sudoku, but has started to become a little bit forgetful of late, with bilateral cataracts, and she wishes if she's able to do most of her activities, that is either sitting and reading or doing the newspaper Sudoku kind of thing, or when she's alone at house and if somebody rings the doorbell and she wants, to see who's come when the maid opens the door, she would like to be happy if she's able to do that. So for our advice for her was a traditional multifocal IOLs, bilateral, so that she has a good distance as well as near activity. And because her sort of intermediate use was quite limited, we could manage to get a happy patient, and now she doesn't need to remember where her separate distance glasses are and where her separate reading glasses are, and she's able to do most of her activities confidently. Another case of what we now are encountering more and more, young patients with bilateral cataract and also very active in their professional life. And now with all of us getting fitness freaks, he also plays volleyball daily, and he drives himself, of course. So he would like to have, as good vision as possible without glasses, but he's heard and he's read, of course, on the internet that multifocal IOLs are bad and they shouldn't have. And therefore our advice for him, having discussed with him, was to consider a low power add multifocal IOL, where he is likely to get a good distance and intermediate vision binocularly. That is, most of his driving as well as his computer office work could be taken care of, with minimal chances of optical dysphotopsia. But of course, for very fine print reading, if he wants to read a book or newspaper in the morning, he would definitely need reading glasses. And therefore, I think it's not just people who are active should not be considered for multifocal IOLs. With these newer low add power or extended depth of focus IOLs, we can extend the patients whom we select for multifocal IOLs. And my last case is a young unilateral PSC cataract, active lifestyle, once again works on the computer all day, and we are not going to be operating his other eye soon because the other eye has a clear lens. So our traditional teaching is, if it's a unilateral cataract, forget about multifocal. Multifocal needs binocular symmetry and the other eye surgery soon. But he doesn't have a cataract in the other eye, or nor a great refractive error which needs clear lens extraction as well. So we discussed, and he was still, he's 45, so not very presbyopic. He's still able to get away with most of his activities for near without glasses. And we discussed the possible option of considering a low add power multifocal IOL, and that could, be interpolated even to an extended depth of field of IOL like the SYMFONY. We discussed with him that his driving and most of his office work should get covered by this. He would, of course, as he progresses with age, and if he compares with this other eye, he'll always find that the operated eye requires a little more light for reading. But with binocular vision, he should be okay even with a unilateral low power add multifocal in this eye. So the take-home message from this case is that the low add power multifocal IOL can be considered even for a unilateral implantation. So I'd like to end my talk here with some of these case suggestions. I would value comments not only from the audience but also from Dr. Ramamurthy, who is I think the pioneer as far as multifocal IOLs goes in our country.